So I'm going to talk to you today about lung cancer. I have no disclosures. I do have a few disclaimers. So this is not actually an overview of the lung cancer staging system. And it's actually not really a lung cancer talk, although it's certainly going to seem to be like one. What I want to do is I want to introduce a concept of a stage shift. And I'm going to illustrate that there is a perception out there that stage dictates treatment, and then I hope to point out the errors of this way of thinking. So this grid actually demonstrates the revised lung cancer staging system, and the groups in red are groups that have a new stage designation in the new staging system that differs from their previous version. And I call these people the stage shifters. And I do that because their stage designation has shifted between the 6th and 7th editions of the staging system. So these 10 subgroups of patients have all had a stage designation change from the 6th to the 7th, some up and some down. Overall, it turns out to be about 17% of patients, their stage designation changed overnight. And this is actually much more of a phenomenon than just lung cancer. So this is the 7th edition of the staging manual. And of the 61 tumor types listed, 26 are affected by this stage shift, meaning that there's groups of patients whose stage designation changed simply by the revised lung cancer staging system, which would be on the order of 50 to 75 million people. So the question is, should the stage change impact how you treat patients? So Peter Goldstraw is sort of, he was leading the effort to revise the lung cancer staging system. And in 2007, he stated that changes, if accepted, will change treatment. I just want to show you one patient here. This is a patient of mine who has tumor involving the left atrium and no evidence of nodal metastases. And the 6th edition stage is 3B, but in the new staging system, they become a 3A. Now, a lot of people are accused of cookbook medicine, where they just go to a staging network or some staging reference and pull a treatment off the shelf. So for this patient, the previous treatment for that patient would just be chemoradiotherapy, more of a palliative, potentially curative approach. But for 3A, we usually give neoadjuvant followed by surgery. So what should we do in this patient? Well, the first thing we did was we asked about this phenomenon. So at 4 different symposia that we were giving lectures at, Frank and I, my partner, over the past year, before and after the talk, we posed 3 patient scenarios: a satellite nodule, which is 2 nodules in the same lobe; mediastinal invasion, node negative, kind of like the CT scan I showed you; and then a big tumor with hilar nodes. And at the beginning of the lecture, we presented those 3 patients with their 6th edition stage. We gave them 4 treatment options, which were chemotherapy, radiation, surgery, or a combination. And then at the end of the lecture, the same 3 patients were presented, and the only change was we had changed their stage designation. And none of the talks had anything to do with how you treat these patients. So the response rate wasn't great. We got a 32% response, but it was over 100 people. And the bottom line is 77% of people changed their treatment just because the designation had changed. So why does this phenomenon take place? Well, the data on how you treat patients is organized by stage. Clinical trials report by stage, and so as a result, the resources that physicians use, such as the National Cancer Network, ASCO, and ACCP, they give all their treatment recommendations by stage. But if you change the stage, does that mean you change how you treat patients? Well, you have to look at how the staging revision was made. So the staging system was changed based on a big composite database that included clinical trial patients, registry patients, and case series. And what was done is they looked at outcome and the changes. This is the 6th edition, and you can see the lines are a lot straighter. It's a lot better prognostic tool. So you have a much better way to determine prognosis, but how does that affect how you treat patients? Well, there's a lot that goes into how you treat patients. Prognosis is certainly one aspect, but comorbidities, what they've had before, the expertise of the treating physicians, it's a multifactorial decision. So similar prognosis doesn't necessarily mean similar treatment. Well, to look at this for lung cancer, we looked at the National Cancer Database, which is a joint venture between the American Cancer Society and the American College of Surgeons, and we looked at lung cancer patients diagnosed between 2004 and 2007. And it turns out there were about 22,000 of these stage shifters. I made that up, by the way, if you're wondering. And so these are those 10 groups of patients that I showed you before whose stage designation had changed. And this is a very confusing slide. The only thing I want you to take away from this is it's really colorful. And each one of these colors is a different treatment strategy. These are those 10 groups. Every one of these columns has the exact same prognosis. And among these 22,000 patients, you could see the treatment plan is wildly different. So similar prognosis does not mean you have similar treatment necessarily. But more importantly, the system that changed the stage classification system did not include treatment in the analysis to change the staging subgroups. So there's really, if the prognosis is information to you that you did not previously appreciate, there's really no data to tell you what to stop doing and no data to tell you what to start doing. And so actually in response to this, the authors, these are three of the heaviest hitters in lung cancer right now. And Lynch is also a major player. But Ramey, Porta, Crawley, and Goldstraw, they're the ones who revised the staging system. So they just had a paper accepted by JTO. Should the 7th edition of the lung cancer staging system change how you treat patients? And this is their conclusion, that making changes in management solely to upstaging or downstaging is just not justified. So it comes down to balancing risk and benefit. So this is the part that actually is about lung cancer. So what do we know about the stage shifters? Well, there actually is quite a bit of data on how to treat some of these patients. I'm just going to whiz through a little bit and try to show you some of the problems that exist with that data. So people that know lung cancer know this trial. This was a negative stage 1 adjuvant chemotherapy trial. But what they did, it was a subset analysis and found that for stage 1 tumors greater than 4 centimeters, there was an advantage to giving chemotherapy. I actually got the primary data for this, and there weren't a lot of patients actually that were greater than 5 centimeters. 95 patients in the 5 to 7 range and only 32 patients greater than 7. This actually influenced another clinical trial to do the exact same thing. This trial called it clinically important differences, but it wasn't statistically significant. But the bottom line is these were both unplanned subset analysis. But this actually became the standard of care for tumors greater than 4 centimeters, which would be this stage shift subgroup. There actually is a new meta-analysis that came out of the Medical Research Council in London that compiled a whole bunch of clinical trials. And I think this is actually more supportive of giving chemotherapy to big tumors without lymph nodes. There was a survival advantage. This is surgery, adjuvant chemotherapy and surgery versus surgery, and this is for stage 1B, and they basically found that there's a 5% 5-year survival advantage if you give chemotherapy. So for larger tumors that are node negative, I do think the best way to go is resection, and adjuvant chemotherapy is reasonable. What about the really big tumors that are node positive? Well, there's the LACE meta-analysis looked at a number of clinical trials that looked at adjuvant chemotherapy after complete resection, and I think this pretty much supports giving adjuvant chemotherapy to these patients. What I think is interesting is sometimes the stage system becomes a self-fulfilling prophecy, and I think you have to be careful of that. So pleural metastases, everybody would say that's the end of the story. They should just have palliative therapy. This actually is from the ISLAC database, and it compared a number of different T staging variants. And before, a malignant pleural effusion was T4. It's actually been upstaged to M1. But I just want to call your attention here to pleural dissemination, 11% 5-year survival, no surprise. But actually, if you resected these patients, and there aren't a lot of them, but only 87 of them that were resected, and you could have left disease behind, but if they had surgery but no nodes, there's actually a 24% 5-year survival, which is counterintuitive. So I think you do have to be cautious in letting prognostic information from similar patients dominate the way of thinking about a disease. So the so-called satellite nodule, one thing that is known is if you have a satellite nodule, your nodal status is important, and most people would agree that N2 disease and a satellite nodule is a bad combination. The same thing is if you find an incidentally discovered nodule in another lobe on the same side at the time of surgery. So N2 is bad. If you think you have a satellite nodule, it's very reasonable. It's actually recommended to do invasive mediastinal staging. The hooker with this is it's often very difficult to know that you have satellite nodules when you go to the operating room. These are 4 studies that looked at the percentage of patients with satellite nodules that were known before they went to the OR, and at best it's 50%. And when you just take patients to the OR and you don't identify a nodule, over 5% of patients will subsequently be found to have another cancer in a different lobe. So it's tough to make recommendations with the satellite nodules because most of the time you don't know they're there till you get to the operating room. T4 by invasion, meaning this is growing into the heart or growing into the great vessels. When you look at all the data, there's a couple of take-home messages. Experts can do this safely. They can take out parts of the heart. They can take out parts of the aorta. And if you can do it safely, you get good outcomes. Really, this is very intuitive stuff, I know. These are just a couple of series of experts who took out parts of the central airway, left atrium. And the bottom line is the mortality is around 9%. The 5-year survival is 30%. If you look at patients who are treated on clinical trials, it's actually pretty similar. Interestingly, the operative mortality is a little bit lower than the experts. And the same thing about N2 disease. So the tumors that are growing into the mediastinum, again, just like the satellite nodules, very important to rule out N2 disease. So if you put it all together, the new cancer staging system gives you new prognostic information, and that's for lung cancer, that's for colon cancer, that's for everything. But you can't use that to make a treatment change because it doesn't tell you what to stop doing and it doesn't tell you what to start doing. There is data available on the stage shifters. Ideally, you want to use clinical trials to dictate treatment, but there are case series and case registries. For instance, this patient of mine who was a 3B, I actually did a mediastinoscopy and resected it on cardiopulmonary bypass, and I actually did that on November before the staging system had been revised, just to illustrate that you don't need a staging system revision to tell you what's reasonable and what's not. So future study is obviously needed. I'm not advocating against cookbook medicine. I think that you need guidelines, and especially when you're treating tumors that you don't treat all the time, but you got to use the right cookbook, because if you don't, you might end up with something other than what you expected. Thank you.